Hi, and welcome to part one of session one of our QI Summit. I'm Todd Harris, a private practice surgeon in Southern California, for those of you who don't know me. I think before I get started, I just wanted to acknowledge the placement of this particular session in the summit. I think obviously the research that the QC does is fantastic. The core insights that we've been watching over the last months have showcased all of the research that has been able to be accomplished through the QC. In addition, the opioid prescribing behaviors of physicians has been greatly impacted again by the QC. But all that research doesn't happen without data entry. It's sort of where the rubber meets the road, right? We can accumulate a lot of data and we might not do research on it, but we certainly can't do research on data that we haven't accumulated. So I think as a QC and as part of the membership committee, which I'm a part of along with David Kripata and others, we want to ensure that the surgeons are having the most streamlined, the easiest, and the most seamless approach to data entry. And so for the QC to put this session first, and for us to be able to hear from some of the high performers who are entering a lot of data on what they think is working best in their practice, again, I think shows that the QC's dedication to improving data entry for us, because that's really what counts when it comes to growing and utilizing the QC. I think there's going to be some upcoming changes to the QC in terms of data entry, and I think that that's great. Again, I think we shouldn't think of the QC as a static creature. It's a living, breathing organism which can be adapted and can change. And so if you as a surgeon are running into issues in the QC, bring it to our attention. Let us know, because inevitably there's going to be other surgeons who feel the same way. So with that, I wanted to get started. So back last summer and spring, Jeremy and Rebecca sent out a survey to all of us in the QC, and 65 of us responded. And the second question was, what percentage of your cases are you entering into the QC? And by the looks of this chart, it looks great. There's a big green bar here, but when you really look at these other three bars, if we add those together, that's almost 40% of the members are not entering 75% or more of their cases. So that's a significant opportunity for us to improve. When asked what the barriers were to 100% participation, obviously makes it's not a surprise, makes sense that it takes too long to enter cases, and or I don't have assistance with entering cases. So again, the barrier to surgeons participating are time and workflow, some things that hopefully we're going to learn more about this morning. We sent out a survey, a poll to a number of surgeons, a number of you, and asked, tell us how long it takes for you to enter different tabs and different sections within the QC for your patients. And again, not to dwell on the exact numbers, but there's variability here. Within each of these sections, there's surgeons who are taking a minute or 2 minutes or 3 minutes. So again, no matter how good we think we are at this, I think there's definitely opportunity to hear from the high performers on what they're doing. So again, we average that out. And if we look at the average surgeon who responded to us, it takes about 13.5 minutes for them to enter each of those sections collectively. So that's not an insignificant amount of time. One thing that we asked each of you was not only how long does it take for you to enter, but who's actually entering that data into the QC database. And again, not to go into the details here on this slide, but obviously there's a wide variety, all the way from medical assistants and nurses down to surgeons. And as we get over towards the operative details, certainly more surgeon heavy. But again, there is variability. So we may hear from some of our high performers on, again, what works for them. So hopefully some of what's working for them, we can all add to and implement within our practice. So a couple of maybe non-data entry points as part of the membership committee that I'm on, along with David Kripata. We're looking at each surgeon's involvement with the QC. Obviously, you're investing your time. We appreciate that. But there are times where certain surgeons who have been engaged tend to lose that engagement, have other things going on. So some of you in the QC may have gotten phone calls or emails from us, literally just to learn what your barriers are. We're not calling or emailing you to scold you or to criticize you or to shame you. It's literally more to listen than it is for us to tell. We'd like to hear what your barriers are, what we can do to try to help improve things. And almost more importantly, to let you know, we appreciate the time that you did spend. And if you can get back engaged, then we certainly would appreciate it. So some of you may have gotten those calls and you may get a call in the future. And again, it's not a criticism. We just want to point things out. So for me, obviously I dropped off in Q2, Q3, but having heard from someone in the QC, that may re-engage me. So again, engagement of the surgeons we already have in the QC is extremely important. And that's why we're here, to learn the tips and tricks on data entry. But again, another small plug for membership as a whole, not only is it engagement, but it's the membership numbers. And if we look at this chart of the membership growth over the years, you can see we did good until 17, but it's tailed off a little bit. If you break this down into the different practice types, whether it be academic, private practice with an academic affiliation, you can see that we as the QC and we as private practice doctors really have plateaued here and haven't really been bringing new surgeons into the fold. So I think what we would like to do is to create a membership drive. We'd really like to engage all of the surgeons who are currently members and ask them to go out into the community and to try to recruit surgeons in. I mean, word of mouth obviously is one of the best ways for anything to grow. And some of you have probably gotten some of these cards in the mail. We've mailed them to a few of the surgeons that we could. And if you take these cards and you take them with you to a surgery center where you operate, and there's other surgeons there, pick a few that you know that are busy and give these cards and say, hey, this is something I'm involved with. Would you like to be part of this? Take it to the hospital with you. Maybe you ask some of your partners who may not be engaged, but this actual physical card that we mailed to some of you, or everybody will be getting this digitally. So again, if you have a friend from residency that you remember, send this to them, forward that to him or her and say, hey, I'm involved with this particular program. I think we're doing great stuff. And we really want to try to help grow the membership, numbers, especially with us private practice docs. So with that, we're going to hear from our high performers. Really excited to hear from 3 different types. We've got Jeremy, Michael, and Jonathan, academic, and then academic with, or private practice with academic affiliation, and then private practice. And again, we know that all of our practices are different, but I think either, listen to the surgeon that's in your type of practice, or even better, maybe take a few things out of each of theirs and see what you can implement within your practice. So with that, thank you very much. And we'll take the next talk with Jeremy. Thanks.